Good morning, my name is Gerry Killeen. I'm an epidemiologist. I've worked a lot with some infections that have things in common with COVID. And because my family and I, we lived in rural East Africa for so many years. I've spent almost 20 years working in East Africa and living there. We raised our kids there. We're very familiar with rapid antigen testing because it's kind of been part of our family life for a long time. I've also used them. I've used hundreds of thousands of rapid antigen testing units for malaria as part of my professional life, doing large-scale epidemiological studies, and we're very familiar with them. I know they're new to most people in Ireland, so we just thought we'd show you what they look like because we always have them in the fridge. It's how we've kept ourselves safe. I'm just going to get the kit from the fridge. Of course, the kit for malaria isn't much use unless you also have the drugs to treat yourself. But this is what for malaria, a rapid antigen testing kit looks like, a kind of family-sized version, and you just pop it open. I'll show you how you do it. For malaria, you just need a drop of blood. Nobody likes this bit. You take out one of the little cartridges. Pop that open there. Put that on the table. I get the little container of buffer. I pop that one there. And now I've got a little alcohol swab. So I use that to sterilize my finger. I keep that handy for later. And I dry that off to get rid of the alcohol, which would interfere with the test. I get a little pre-packaged needle with a seal and a little drop grabber. Okay, so there we go. Pop the cap off that, and then just there we go. So this little thing will always grab exactly the amount of blood that you need. For it won't be blood for COVID, but that's basically it. And then you pop that into the little hole here. That's the correct amount. Pop that in there, and now put my little alcohol swab on there, and I put 5 drops of this stuff in there. 1, 2, 3, 4, 5. And now I'll leave that for 15 minutes. At the end of 15 minutes, the test will be done. You can see the buffer now is pushing the blood sample through that blotting paper strip, which contains antibodies which will grab the antigens from any malaria parasites that are in there, and then there's other reagents in there that will react to produce a colour. If I get 1 stripe, then it means the test worked, and if I get 2 stripes, it means the test worked and I've got malaria. Now, that's going to be a negative test today because I haven't been anywhere with malaria for 10 months now, I guess, 8 months since we moved back from Tanzania. But in the meantime, I'm going to explain to you why these things can be so useful, why they give us new options for dealing with COVID. You can see how simple and practical that is. You can already see the negative control strip coming up. You can see that line there. So I already know that this little kit is doing its job. That's the little line that tells me all the reagents and antibodies are reacting correctly, and that I can interpret the results of this strip at face value. Now, if I've got a low density parasite infection, I'll have to wait 15 minutes before the second stripe comes up. So I'm just going to leave that there for you now and explain to you why these things are so useful and why they can really help in the fight against COVID. The reason is that, PCR tests are great, they're highly sensitive, they're more sensitive than this, but you got to do them in a lab. There's a little mobile version, like a lamp machine, but ultimately you can't do it in your kitchen like this, you can't do it out, anywhere. And these little kits have been brought to the furthest, most isolated villages in the most distant corners of Africa, and have been used to diagnose many people with malaria, amongst other things. So they're very practical. They're much cheaper. You know, this box here cost us 48,000 shillings for 5 tests. You know, so that's a lot less than 20 euros. And so you can afford to do an awful lot of these. And, you know, just because they're not perfectly sensitive, you know, that's not such a big issue. If, you know, many times in the past we've tested our children, sometimes I've had a negative test result from one of these that I don't trust, because I know how the parasite densities can vary inside a person, and also the test has its own sensitivity limitations, like any test. So you just do a second test the following day when maybe the parasites are up. And in the case of COVID, you know, when you might just get that extra bit of virus in the swab and you can retest. So the solution to imperfect sensitivity, and also to just being unlucky sometimes. Sometimes you test a patient and it's just the wrong time, you don't get enough antigen, and so you miss that infection. So you just do them second time or a third time if in doubt. Good public health people know how to use testing kits once they understand their performance characteristics. So for me, these are technologies that we don't just evaluate in the lab in the hospital, that we take straight out into operational research studies, which means we evaluate them in use, and we don't use them to replace the PCR test that's used for standard surveillance. Instead, we use them to do things we're not doing at present, like high frequency serial testing of essential workers. You know, so why would that make a difference, and why would an imperfect test be so useful? Well, let me explain to you why that matters so much, and particularly in relation to COVID. COVID is different from the diseases that we've used contact tracing and isolation to tackle before. And the reason it's different is because most people who get COVID will be either asymptomatic or more likely what we call paucisymptomatic. Now that means that you have mild symptoms, and they're so mild and they're so vague and they're so similar to all the things that you've had before that you tend to brush them off. Okay, so most people who get COVID, you know, they're gonna brush it off most of the time. So the problem is that it means COVID can go through multiple people before it becomes obvious that somebody gets really sick. So if I was doing contact tracing for Ebola or SARS-1, and SARS-1 is the closest living relative of COVID, the transmission chain would look like this by the time somebody gets sick enough to be tested or to be really obviously sick with that particular disease. So believe it or not, there is such a thing as an asymptomatic, or at least a paucisymptomatic Ebola case. It does happen. It's rare, but it does happen. So it is possible that somebody gets Ebola at the base of this transmission chain and passes it on to maybe 3 people before that person, you know, in likelihood, this person will get sick and this person will get sick. You know, in unusual cases, this person might not get sick, but you've certainly got 2 of what we call an index case very early in the transmission system, which means if I trace back a few days, I can always find the person who kicked off the whole thing, and so I can break that transmission chain at the root, okay? Because it doesn't get very long before we notice. Now, this is more like what a COVID transmission chain can look like, because the first person who gets it, you know, might not feel the symptoms, or might be in a marginalized ethnic group, or doesn't have great English, or, you know, whatever it might be, whatever reason. There's lots of reasons why somebody might not either notice that they have COVID or report for testing. Or in our system here in Ireland, they might not qualify for testing if they have atypical symptoms, which covers about 20% of people. So then it goes on to the next person who might not notice, and then it gets on to the next person. And so when we're waiting on symptomatic surveillance, it might be, might be this person. So it might get this far and this wide with so many people infected before, this person notices and turns up for a test. This person notices and turns up for a test. And this person notices and turns up for a test. So sensitivity is less of an issue. The issue is that so even if we miss one of these cases, that's one of these branches that we won't be tracing. But the big issue is if I catch this person and I trace backwards, maybe if I'm lucky, I'll certainly snap off that branch, and then somebody over here gets noticed, and maybe if we're lucky, we trace that person. But we've still got branches that are active that haven't been noticed. Maybe I can pick off this one, but basically, because we're picking up that transmission chain too late, we're always going to have branches that we miss, and each of these will be identified as a separate cluster when in fact they all belong together. The trick is to identify the transmission chain before it gets too long, to identify the second person, and the latest the third person. So if you're testing people, people who are essential workers who are at increased risk, where most of the transmission will be occurring, if you can test them about once a week, then you're probably going to pick up, if you test these 3 people here, even if your test has imperfect sensitivity, so you missed this one, you missed this one, your chances of missing all 3 are very low. So once I identify this person, I can trace backwards, I find the person who infected all of these people, and I break the transmission chain at the root. And that's why rapid antigen tests can do things that we just can't do with PCR. Fortunately, mine is negative today, so that's good news for me. But the trick is with these things, get them into use, give them to people who know how to work their way through these things, and let's get on with it. Thank you very much. Take care.